let's get started. So this morning we have one of our fellows, Dr. Liu, known as AKA Rik. He went to residency at Kettering Medicine Center, internal medicine, and being our fellow this year. And he will further be matched. He's matched to pulmonary and critical care at Metro Health. That's where he will continue his training starting in July. And he is bringing us his topic today, REM behavioral disorder and treatment. So without further ado, I will hand the stage over to Rik.
Morning, everyone. Let's get started. So today my topic is REM sleep behavior disorder and its treatments. I have no financial disclosure conflicts of interest in those. So this is the objectives today. We'll talk about REM behavior disorders and its diagnosis, differences between the different types of RBDs, and the differences between RBD and other non-REM-related parasomnias. We'll talk about the neurophysiology pathways of what atonia is and how that's affected with the RBD. And lastly, we'll compare the different treatment modalities for RBD. Contents. So in an overview, rapid eye movement sleep behavior disorder is a type of parasomnia. It's characterized by dreaming inactive behaviors that emerge during loss of REM sleep atonia that is noted in the PSG. The severity ranges from benign hand gestures to really hurting yourself, like punching yourself or the bed partners. Usually, the patient presented for medical attention from an injury to either self or their bed partners. It's a well-known fact that RBD is a prodromal syndrome of alpha-synuclein neurodegeneration. A lot of patients who was diagnosed with RBD will eventually demonstrate signs and symptoms of Alzheimer's, Parkinson's disease, multiple system atrophy, and dementia of the Lewy bodies. Adults, that's right. I'll briefly talk about RBDs in younger populations as well. So the prevalence is about 0.38 to 0.5%. It's not a lot, but it's definitely it should be recognized in the public. It's more prevalent in patients with psychiatric disorders. They thought most likely related to medication that they prescribe the antidepressants for psychiatric disorders. It's predominantly male. I'm talking about the classic idiopathic RBD. In a study of 93 patients, only 12 of them were female. So majority of them are male. It's a disease, a typical disease of an elderly person. The risk increases after the 6th decade. The mean age of onset is from 52 to 56 years old. There's no death has been reported directly to idiopathic cases of RBD, but in those 93 cases, 32% of them had serious self injuries, and 64% actually had assaulted their spouse. And 2 of them has some very serious trauma from subdural hematoma. So they can suffer from some very serious consequences there. It's not active.
One guy at the VA had there. 2 years to get better. Get up, rated.
So there has been some studies show there is some relationship between narcolepsy and RBD. So it's RBD is present in 15 to 30% of the patients with narcolepsy. Actually, narcolepsy is the most common cause of secondary RBD. And when in these populations in narcolepsy, actually, RBD presents in younger population with narcolepsy, and the frequency is equal between male and females in RBD with narcolepsy. Study by Nightingale showed that in 55 of narcoleptic patients, 36% of them had symptoms suggestive of RBD. The mean age in this group were younger, of 41 compared to 52 to 56 years old. In fact, patients who had more classic symptoms of cataplexy or those very classic symptoms of narcolepsy, of sleep paralysis or hallucinations, 68% of them had RBD versus the 14% who does not have those classic symptoms of narcolepsy. So narcolepsies with more classic symptoms of cataplexy and other symptoms has more tendency of having RBD as well.
The other thing is you triangulate that with a Lewy body disease. I don't think the narcoleptics are at any greater risk of Lewy body disease. So just having the symptom doesn't means something in your brain, and narcolepsy is different.
Yeah.
The trajectory for Lewy body.
Yeah. Talking about the alpha-synucleinopathies, there is, of course, very well known, very strong correlation between RBD and the dementia, Lewy body, Parkinson's, and all that. This is a very large study, prospective follow-up, 24-center international RBD study group, more than 1,000 PSG confirmed idiopathic RBDs. They started initially without Parkinsonism or dementia. The average age was about 66 years old, and the majority of them male. Average follow-up was 4.6 years. Actually, a very surprisingly high overall conversion rate from idiopathic RBD to overt neurodegenerative syndrome, 6.3% per year. That's very high. And you can see the graph here. The disease-free survival declines steadily over the course of more than 14 years. Actually, at the end of the 12-year follow-up, 73.5% of the patients who did not have symptoms of Parkinsonism or dementia actually developed when they were diagnosed with RBD in the first place. So during my literature research, I don't think I can find a very definitive definition of categories of RBD, but these are the ones that I think were agreed upon. But the most common one is the isolated or idiopathic RBD. This is the one that's associated with alpha-synucleinopathies, Parkinson's disease, and Lewy body dementia, and all that. Secondary RBD is due to underlying cause, such as narcolepsy, some CNS diseases, such as encephalitis and Guillain-Barré syndrome can cause RBD. And there's a class of drug-induced RBD, which usually involves in patients who takes antidepressants. Also can be seen alcohol withdrawal, also caffeine use as well. Sometimes some cases were reported. And last is the pseudo RBD, which is associated with untreated OSA. The resolution occurs usually with adequate treatment of OSA in this population. Coming up next is a table compared different types of parasomnia or nocturnal seizures to RBD. You can see that the non-REM parasomnias in the first three, confusion, arousals, sleep terrors, sleepwalking, they typically arise at the early or the mid part of the sleep stage. Sleep terrors come with a very aggressive CNS activation, screaming, paresomnias, and all that. There is usually a post-event confusion with no recall of the events, and these kind of symptoms are usually seen in children. younger ages, and there's a very strong, and there's no strong correlation between the organic CNS lesion in these kind of population. The nightmares and RBD occurs in the later part of the sleep, during REM stage. The RBD has a lot of motor activities, and it occurs in motor adults. It is associated with CNS lesions. The nocturnal seizures can happen in any stage of the sleep, also accompanied by motor activities, and it's strongly correlates with CNS lesions. So how do you diagnose RBD? In ICSD-3, there are 4 criteria that must be met for a RBD to be diagnosed. So number 1, you have to have a complex motor behavior, either a motor or vocalization. It has these kind of behaviors has to be documented by PSG during REM sleep or based on history of presumed to be happening during REM sleep. You have to have a PSG diagnosis of something called REM sleep without atonia, or REM. And obviously, like all the other sleep disorders, not explained by another sleep disorder. There is a term called probable RBD. It's sometimes used when our PSG is unattainable or unavailable, and REM sleep is not captured during PSG, but clinical history is still highly consistent with RBD. There's a few screening questionnaires out there to screen for RBD. Surprisingly, their sensitivity is very high. For example, this REM sleep behavior disorder single question screen basically asks, have you ever been told or suspect yourself that you seem to act out in your dreams while asleep? Just by asking this question, there's a sensitivity of 94%, specificity of 87% in detecting RBD. And there's another more comprehensive, more validated diagnostic called the male sleep questionnaire. This is used to screen older patients with cognitive impairment or Parkinson for RBD. It's mainly used to ask the vet partner, and like I said, 64% of the vet partner actually was assaulted. Actually has a higher percentage from the self-injury. So basically, these questionnaire asks basically motor movements in the question A, what kind of movement they have, such as injuries to themselves or the second question asks about leg jerks, and the third question asks about restlessness. Just by asking question number 1, it has almost 100% sensitivity for RBD, and specificity is 74%. There are some false positives reported by asking these questionnaires, especially for patients who has OSA or untreated OSA. They tend to have dream enactments without the actual classic findings of REM sleep without atonia and PSG findings and support the diagnosis of idiopathic RBD. Here is a patient that I saw in the VA. I just want to draw attention into this leg EMG here. This is the stage of REM sleep in a patient. Compare this REM stage to a non-REM stage. You can see a very distinct difference between the sustained contractility of the leg EMG in the REM sleep compared to the N2 sleep in this patient. And these are 4 different EEGs. In graph A, there is no leg EMG's activation during REM sleep here. That's definitely a normal EMG without sleep without atonia. In figure B, there is a very distinctive increased EMG tone has the definitive the REM sleep without atonia. These two are equivocally increased EMG tones. See here. The scoring manual also has a very detailed guideline on how to score these. But basically, to summarize, you either have to have excessive, sustained, or transient muscle activities during REM in either chin or limb EMG. And there's something called REM sleep without atonia index, which is the percentage of stage REM epochs that meets the criteria above. We'll move on to the more boring or difficult part of the presentation, which is the neural pathways of how RBD arises. We'll first talk about how a normal REM sleep is being controlled in normal sleep. The slides I presented to you last month. The core activating REM generating circuits is at the mesopompal junction. It's close to the locus cerealis, and it's in the nucleus called subcerealis nucleus. The other name for this is the sublateral dorsal nucleus. The predominant neuron in these group of cells are glutamatergic, so glutamates. They also found a lot of GABA cells that has been implicated in REM sleep control. Glutamate and GABA are the main key players. They found that by activating these subcerealis nucleus, they can induce REM sleep motor atonia. And by deactivating or by having lesions in this subcerealis nucleus, they found that REM sleep without atonia has they found that it can prevent the REM sleep without atonia or reduce REM sleep events. So this subcerealis nucleus sends activating signal to this ventral medial medulla and the spinal cord, and that in turn causes inhibitory signal to the muscle motor neurons. The other thing, the key player they found was acetylcholine, which act as a facilitator for this whole pathway. It enhances the glutamate driven postsynaptic excitation. So basically, acetylcholine facilitates more glutamate release and cause more inhibition. So three key players, glutamate, GABA, acetylcholine, all act together to induce REM sleep with atonia, cause muscle relaxation and inhibits muscle fibers. What happens in RBD? So in RBD, the circuits between subcerealis nucleus and the ventral medial medulla has some lesion, which inhibits the inhibitory signal to the muscle, and then that will promote motor behaviors during REM sleep. This is another graph. Basically, in normal cases, there is a positive signal going to the medullary inhibitor region that causes inhibition to muscles. In RBD, there's no excitation from the subcerealis nucleus from pons to the medulla, and there's no inhibitory signals that can cause backup of RBD. So this is a summary. GABA glutamate or inhibitory neurons, they send signal to subcerealis nucleus and then to ventral medial medulla and cause inhibition. Acetylcholine is kind of the augmentation or enhances glutamate release to enhance the inhibition of motor neurons. The other player I want to touch upon is serotonin. So we know that a lot of study has shown that SSRI. Anyone having audio issues?
Martin.
Other than Marvin?
So we'll shout a little bit.
Okay.
Stranger voice.
Not me, okay. Oh, intermittent, okay. Maybe we should bring the mic a little closer to. Okay. So the other key player I want to talk about is serotonin. There are a lot of research study has shown that SSRIs increases the risk for RBD. Is actually the drug-induced RBD. Almost all antidepressants can trigger RBD, except one of them, which is bupropion, which does not contain serotonin activation signals in bupropion. There's a paper showing the serotonin antidepressant associated with sleep, REM sleep without atonia, and then there's another paper describing the hypothesized mechanism of how serotonin works in sleep. So basically, serotonin is wake promoting. It promotes a quiet waking state with reduced cortical activation. A study has shown that increased serotonin suppresses REM sleep. They suppress the REM sleep by the receptor of 5-HT1A, and there are 20-something 5-HT receptor out there, and 5-HT1A is the wake promoting receptor. It acts on different areas of the brain to suppress either non-REM or REM sleep. In REM, they found that it suppressed the REM on brainstem cholinergic neurons by these receptors in rats. And in non-REM sleep, mediated by the postsynaptic inhibition of the VLPO neurons. Moving on to the next topic, we'll talk about the treatment of RBD. The main focus of the treatment is to reduce these behavioral events and sleep injuries, especially by simply changing some sleep environments, such as asking a bed partner to sleep in a separate room or bed, removing furnitures and with sharp edges, or sleeping on a lower level in a mattress closer to the floor to prevent falls from the bed. Next step will be trying to tease out or try to find any medications or substance that may induce RBD. And if necessary, we'll talk about the pharmacotherapies for RBD as well. So it's the mic that has to be closer to the presenter.
Or the presenter being closer to them. Immediate grasp of the
So we know that serotonin, increased serotonin level, or SSRIs and NRIs, can cause induce RBD. So TCA, monoamine, SSRIs, mirtazapine, and caffeine and chocolate was also shown to induce RBD as well.
How much?
in synthetic. Right. It was not 100 versus 3,000.
Well, over the weekend, somehow ASM probably know that I'm doing a presentation. They updated these guidelines on April 1st to help me out a little bit, but basically they recommended 4 main medications in their guidelines. So the first medication I want to talk about is the clonazepam. Clonazepam has the longest history, I think, since 1986 that they started using clonazepam for RBD, which has been fairly effective. It's a long-acting benzodiazepine, promotes GABAergic, which causes further inhibition of the neural pathways.
The half-life is like 8 to 10 to 12 hours.
It's very long. I'll talk about it as well. It's the most common prescribed medication since its discovery to treat RBD. Something to note is clonazepam, they reduce dream enactments, promotes muscle relaxation, but has very minimal changes in REM motor tone in PSG. So if you prescribe clonazepam empirically just to prevent serious injuries before a patient was formally diagnosed with RBD. So patient is on clonazepam and they do a PSG. You can still see REM sleep without atonia because it has much less minimal reduction in the PSG findings in the REM motor tone. Compared to melatonin, which I will talk about, which will act a little bit different. They usually respond fairly well with lower doses of less than 1 milligrams. It's used 30 minutes before bedtime. Higher dose has been described to also be considered if it's tolerated. The effectiveness is fairly high at 80 to 90% actually, if the patient is able to tolerate without any contraindications. Is considered as a controlled substance, and it's listed in Beer's criteria as well for older adults. Half-life is actually 30 to 40 hours, very long, cause morning sedation, confusion, and depression as well. The other thing to note is that a lot of patients actually had both RBD and OSA together, and it may worsen OSA. So make sure we screen for OSA and make sure OSA is adequately treated because it can cause both peripheral respiratory muscle suppression and central nervous system respiratory suppression as well. Next medication that came into the favor of use is
for just a second.
Sure.
Somewhere in my mind it was 12 hours, but 30 hours would mean that to get to a steady state, you'd have to take it. You can take it once a day because its half-life is more than 24 hours. And it would take you like 30 days to get to a steady state.
Mm-hmm.
So that's really wild.
Yeah, the literature, I'm doing a very quick search, 30 to 40 hours, 30 to 40 hours, 20 to 50 hours, 20 to 80 hours is surprisingly long. 19 to 60 hours. Yeah.
So I've had a patient who had a lot of problems with it in terms of next day sedation. And I put him on a shorter acting benzo, just because that's the action of clonazepam.
Mm-hmm.
And put him on it, and I got tremendous pushback by the pharmacologist that sat there and said the clonazepam was the only recommended drug. And it did for them. So we used lorazepam. So I wonder whether or not lorazepam is a shorter acting drug.
It's
Still do the same thing.
lorazepam, yeah, it's much shorter.
Yeah, but I mean, I don't know if they talked about it.
I think I'm not digging into deeper of other benzos, but clonazepam has the.
I don't, they always talk about it. I just said it and said, well, use a shorter acting.
Yeah.
Doesn't build up.
Mm-hmm.
And I was really floored by the pushback by the pharmacologist saying it was not the right drug.
Yeah.
It's the right class.
Mm-hmm.
Right.
Yeah.
Anybody else encounter that at all? Or think about it? I mean, right now, everybody goes down to melatonin, right? They go to melatonin. That's what they do. Oh, sorry.
Dr. Ibrahim asked, she used clonazepam for the same reason. From the ASM guideline, there's no mention of clonazepam.
So you're out there on a limb there, Sally.
I'm surprised. We see that clinically all the time. I guess somebody needs to look into that. So, yeah, thank you.
At least make a comment. Letter to the editor of RBD. Still struck by 20 years later with using a 30-hour half-life drug to treat an 8-hour problem.
Right.
Okay.
Thanks.
Okay, next we have a melatonin. So melatonin is like I said, more favorable to some populations due to its more safer drug profile. It binds to M1, both M1 and M2 receptors. They found that it actually suppresses REM motor tone and renormalize the circadian feature of REM sleep. Something that I want to talk about is in normal physiologic conditions, the REM sleep episodes the frequency of REM sleep gets longer as the night goes on, and they increase over the sleep period of the REM index. This is found in normal physiological conditions, but in patients with RBD, this kind of progression is lost in patients with RBD. They have found that the usage of melatonin improve the symptoms, even persist for several days even after melatonin is discontinued, but then gradually reemerge over the next several weeks. It's a small study of 8 males, 84 years old, with PSG confirmed RBD. They enrolled in a 2-part randomized, double-blind, placebo-controlled crossover study. They started with 3 milligrams of melatonin in this study. They found that melatonin significantly reduced this PSG finding. They reduced the REM sleep epochs without atonia, 39% versus 27%. Compared to the clonazepam I talked about, it has a very minimal effect of the PSG findings. Also, there is significant improvement in clinical outcomes in these patients. So, starting dose of 3 milligrams at bedtime, it may be titrated up to 15 milligrams per ASM guidelines. Data on higher doses are not available. And combination therapy has been used with both clonazepam and melatonin. If monotherapy is inadequate, there has not been a lot of data examining the combination therapies out there. Also, there has not been any research articles comparing the extended release melatonin and the short-acting melatonin. As we know, melatonin has a shorter half-life. The other 2 medications that we don't encounter that often for the treatment of RBD, but it is in the guideline, is the first one is a transdermal rivastigmine. It's an acetylcholinesterase inhibitor. Basically, inhibits degradation of acetylcholine, so overall increases cholinergic effect. Remember back in the diagram, acetylcholine is one of the key players to augment the REM sleep with atonia by facilitating the glutamate release in the subservicus nucleus that causes inhibition. It's administered through a transdermal patch. The studies of this transdermal rivastigmine came from an article from a patient with a mild cognitive impairment with RBD. The efficacy of isolated RBD is not well known for this medication. Side effects include skin irritation, nausea, vomiting, headaches, and bradycardia.
Anybody use it? Anybody on the call use it?
The other medication, Mirapex, was also found to be somewhat effective in a very particular group. It's a dopaminergic agonist. It's used to treat motor symptoms of Parkinson's disease, restless leg, periodic limb movements. The mechanism is uncertain because the relationship between dopamine and RBD has not been very well understood. The patient who was studied under these studies, who was prescribed from the Mirapex, had increased PLMDs. So the idea was Mirapex likely reduces dream enactment by treating the underlying sleep fragmentation condition, PLMD.
You believe that?
Well, that's my whole understanding of how REM sleep, how RBD is actually. So basically, I think what happens in RBD is, so with all the parasomnias,
Yeah, but
What-
with this,
with which one?
PLMs occur in REM sleep,
Um,
not often.
not often,
So
but
you suppress the behaviors in non-REM sleep and helps REM sleep, is that right?
but I think the whole idea is really consolidate the whole sleep
Yeah.
to reduce sleep fragmentation, because
Fair,
the idea of parasomnia arises from sleep-wake transitions, like similar to non-REM parasomnias. It came from
fair enough.
the sleep transition to wake. Same with REM. If you consolidate REM, make the REM more consolidated, reduce the awakening from REM sleep, you may reduce the burden of the RBD. Your internal connection is unstable. Okay, so basically, that's wrapping up my presentation. So RBD is a form of parasomnia. It's characterized by dream enactments that usually cause harm to self or bed partners, and loss of REM sleep without atonia and PSG findings. It's highly associated with alpha-synucleinopathies. It's also seen in narcolepsies, OSA, and other medications, especially antidepressant, except bupropion. The pathway comes from the origination of the subserous nucleus, signal to the ventral medial medulla, and cause inhibition to the skeletal muscle neurons. And the key players are GABA, glutamate. They are inhibitory neurons, and the acetylcholine kind of augment the glutamate action. Serotonin is another key player for wake promoting neurotransmitter, and the 5-HT1A receptor is responsible for the inhibition of the REM on brainstem cholinergic neurons. We'll talk about the treatments of the RBD.
It looks like they just fell off.
I think the computer got disconnected in the desktop in the grand round room.
If you're still connected to your laptop,
I am.
you can always switch over and just present from your laptop.
I'm presenting from, well, I can do that, I guess.
That's
I'd like to hear, did they talk about the pediatric management in this new guideline?
No, the guideline did not.
Any particular clues from Sally might have, and Dr. Abraham might have about pediatric management? How about you?
Is it rare?
That's why they look for habits.
But if you're in a place like this with 3-4 million people, you're gonna find it very big. Right. Well, how many, that's what we like to ask, is how many do you see, and what do you see, what do you see in Italy? Right. What do you see in Georgia? Where that sort of stuff might be, you've had, your child has spell, right? I mean, that's what you can say.
I've seen it.
Or maybe like, for example, we don't really see it for by that age, adolescent, when you get strictly their home.
Well, the meetings we're talking about, say they see it, and then the next question is, well, do they all get Parkinson's, right? And they go, no. So, well, that one goes there. You know, are they dithering idiots at age 20, 15 years after a diagnosis? No. Right?
Yeah. No, that's.
I'm trying to connect back.
The way it's just not good.
Not sure.
I think it might be worthwhile.
I think you're back now.
Back. Now, I'd like to hear if Sally has any comments about pediatric management, prevalence, and detection.
Yeah, usually it's uncommon, but it's usually secondary. So perhaps that's why they didn't touch it in this review. There's not enough data, you know. It's nice if they could. So thanks for asking the question. In future guidelines, it's nice to have like a pediatrics, you know, section. Well, I think you've addressed a need that we can potentially do in the future. But it's mostly secondary, so it doesn't have the same sort of things here. I don't want to interrupt Rik's talk if you're ready to roll.
Rik, do you want to just continue the presentation and the discussion from your laptop?
Okay, so
He's been talking.
oh my gosh,
Sorry.
I had. Okay, take 3 of the summary. Sorry, I was muted.
Okay.
Okay, we're back. Because I was muted, I was talking to them. So RBD it's a form of parasomnia. It's characterized by dream enactment behaviors that cause self-harm or bad partners. And there are PSG findings of loss of REM sleep atonia. Highly associated with alpha-synucleinopathies. It also can be seen in high percentage of narcoleptic patients, also in untreated OSA, and some medications, especially antidepressants, except bupropion, which does not have serotonin properties. The neural pathway comes from the subthalamus nucleus that sends signal to the ventral medial medulla that causes inhibition to the skeletal muscle neuron in normal sleep. And GABA glutamate are the key inhibitory neurons. Acetylcholine augments this action by facilitating glutamate release. Serotonin is a wake promoting agent, especially acting on the 5-HT1A receptor that causes postsynaptic inhibition of REM on stem cholinergic neurons. We talked about the medications. Well, the treatment of RBD, the number one not to forget is really caution the patient about the safety side of RBD, and then try to target the medication or other things that may worsen RBD. And then, of course, the medications. Clonazepam it's very effective medication, but should be used cautiously due to its safety profile. And melatonin has also shown to be effective at 3 to 15 milligrams. And the other 2 medications, the rivastigmine increases the choline level in the body, and pramipexole. And this is a question. So we have a 57 years old male evaluated for violent dream enactment. During sleep, he sometimes appeared to be acting out on a dream, and wife reported very violent behavior that he has hit her several times. Now she no longer shared the bed with him. When patients awakened from the episode, he reported recalling fighting in a war which he encountered during his service in Vietnam. Episodes tend to occur more frequently in the later part of the night, approximately 3 times per week. He was diagnosed with depression a few months ago and was started on venlafaxine and was noted to have even more violent movements recently. In one instance, he broke his finger during one of the violent movements. He underwent video polysomnography and was REM sleep without atonia was observed in multiple epochs, but no violent behavior was recorded that night. Study did not suggest that of OSA. He has no other significant past medical history. What is the most optimal treatment option for this patient? Now, does this patient fits all the 4 points of ICSD-3 criteria for RBD?
Yes, you can.
Yes.
Yeah, it does.
Yes. So number 1 is you have to have dream enactment. That's movement asleep, right? Number 2 is you either have to have video observed dream enactment, which the patient did not have. I'm sorry.
I said blessing.
Oh.
Yeah.
Either have video PSG observed dream enactment or have presumed those enactments that occur during REM sleep, which he does have characteristic findings of dream enactment during REM sleep, such as it occurs at a later part of the night. He's able to recall the events. It's more consistent with REM behavior disorder. And number 3, you have to have diagnostic finding from the PSG that's showing the REM sleep without atonia. And lastly, it's not caused by the other conditions, but in this case, the venlafaxine exacerbates this RBD.
So he had symptoms prior
Yeah.
to going on
Yeah.
venlafaxine. Okay.
It just made it worse.
Okay.
So what's the best optimal treatment for this patient? Do you want to increase or taper down the vaccine and or 12 melatonin or diazepam?
A, no, A is no,
Yeah.
B is possible. B is no, B is possible.
So it's basically.
B or D, according.
Yeah, so I don't think there's a 100% correct answer for this one. So D will be more appropriate in my
So
case.
you got safety though.
Yeah. Yeah,
Which is 0.
so,
After you institute safety,
right,
head out sleeping bags, and things of that sort.
yeah. So patient has symptoms of dream enactment, violent behaviors with imminent harm to self or others. He already broken with his one finger, and his wife no longer sleep with him. PSG was diagnosed. They showed REM sleep without atonia, and then venlafaxine is a class of SSRI, SNRI, which are known to exacerbate RBD. Due to significant risk of further self-injury, more potent treatment approach was preferred in this case without any contraindications. Venlafaxine should be probably weaned over a long period of time. Now, venlafaxine is one of the very long-acting antidepressants, and the benzodiazepines also will help both the treatment of RBD and help with the withdrawal side effects of venlafaxine as well. And that's the end